My name's Kelsey. I think I've met everyone here mostly. It's Kelsey. Thank you to Team Sono, specifically JFK, for all of his knowledge and expertise and resources, and for Felipe, who said, I have no notes for your presentation. I want you all to picture this. It's Monday, it's 8 p.m. We are in the front pod, not the back, we're in the front. What kind of emotions that elicits? And we're understaffed. Someone called out. The board is so red, and you just pick up this next complaint that says, my neck hurts. All right, musculoskeletal pain. Let me order some lidocaine patch. I'm going to shotgun some Tylenol. You're thinking ahead, all right? But then you go and you talk to the patient, and you find out that they are a 34-year-old man. They have a medical history of obesity. They're coming in with neck stiffness, and then, oh my God, they're actually having a fever. Okay. You talk to them a little bit further, and they're not really making sense to you. They're saying things like, we're at Bellevue Hospital. No, we're at Kings County. All right, they're altered. What do you want to do for this patient? What? Oh, okay, yeah. Okay. So, despite your best efforts, I think no matter what road you end up going down, you are eventually going to go to a lumbar puncture, which brings me to my talk today, which is going to be on ultrasound-assisted lumbar punctures. Emphasis here on the assisted, because as we will see, we can use ultrasound to assist the procedure, but it is not a dynamic visualization of your needle going in. It's a way to enhance your technique, all right? Some of the learning objectives today, I'm so sad that he's not here, but we're gonna review the setup for ultrasound. We're not really gonna focus so much on the procedure itself. We're gonna talk more about image acquisition. We're gonna talk about the data. We are not gonna practice on Dr. Silverberg. If he was here, maybe we would consider that. Katie also used this meme, which is so embarrassing, but I'm gonna take you all from this to this. That's a champagne, tap. Yeah. Okay. So a little bit of a reminder for anatomy, since it's been a while since we looked at, drawings of the spine. When we go through with our needle, there's like a lot of different layers. It's like a classic UWorld question. First, you have to go through the skin. You have to get through all those ligaments, interspinous, supraspinous. Eventually, you're going to pierce through that ligamentum flavum. That's going to be that pop that you hear that we talk about into the epidural space, dura and arachnoid matter, and eventually the subarachnoid space. So when you think about all of these layers that we have to go through, it's kind of a lot. And there's no direct visualization. It's more based on feeling. And already that kind of scares us. We're not used to so many landmark-based procedures anymore now that we have all these advanced imaging technologies. This is a spine. As a reminder, there are different parts of the spine. As we will see with our ultrasound, it's helpful to remember the anatomy so that we know what we're looking at with the sono. Specifically, that part that juts out from your spine, the bony ridges, we call those the spinous processes. And that is going to be key to finding where you go with your needle with this procedure. On either side of your spinous process, you're going to see like a flat ridge that comes out. That's the lamina. And then on the lateral sides are those the transverse processes. What probe would you use for this procedure? I'm hearing curvilinear. Okay, yeah. And would anyone use the linear probe? Yeah, why? Resolution, yeah, oh, y'all are so smart. Yeah, so you really can use any probe. You can even use the phased array probe or the cardiac probe if you want, especially if someone has like abnormal spinal anatomy, they've had surgeries, and it's a really small space to get through. As long as you can set the depth of your probe to at least 8 centimeters, you can use whatever probe that you want. So I'm going to talk about the curvilinear probe, but it really doesn't matter so much. What does matter is making sure that your probe is perpendicular to the skin. and avoiding fanning. To be honest with you, we're going to talk about the setup of the procedure. The hardest part, I think, is going to be finding a skin marker. Yeah. Has anyone ever seen this? Well, oh, it's in the lumbar puncture kit? Oh, okay. Oh, great. All right. So it's in the kits. I didn't know that. But regardless, if you can't find that, I was just informed this morning by JFK that you can use a Sharpie. This part, yeah. This part, it doesn't need to be sterile, right? So if you're just using whatever pen that you have in front of you, that's fine. The reason why we want to use a marker and not like, you know, sometimes we like MacGyver different ways, like we'll use a cap or we'll like suction with a syringe. You really want to be able to do the marking because we're doing 2 views with our ultrasound. We're doing transverse and longitudinal, and we're marking at midline. We mark in the transverse position, but also the longitudinal position, and you'll see that we actually just connect the dots and it becomes X marks the spot of where to go. All right, so initially we're gonna place our probe in a transverse position. Probe marker is gonna be facing the left, and the purpose of the transverse view is to find midline, which is arguably the hardest part of this procedure. So what does that look like on ultrasound? Where is the spinous process in this image that we have here? The shadow, yeah. So you like Dr. Morales is like behind you whispering in your ear, like, oh, if you see black, you're on bone, right? We've all heard that before. Usually you can see a hyperechoic rim at the top, but not always. You see that big shadow right in the middle, that's probably where your spinous process is. There are other things that we can identify on this image. Does anyone recognize any other anatomy? Skin, oh yeah, skin, yeah. Muscle, so like seeing like these striation like darker gray circles on either side of the spinous process, that's probably your paraspinal muscles. You can see the lamina, which is the flatter part of the vertebra, and then the transverse processes most lateral. So honestly, this is like a really great image. It's not always going to be this high resolution. As a reminder, anatomy. Now, this view here is using the linear probe, and as you can see, we can still make out a lot of our structures, and it might even be a little more obvious because of the high resolution. The spinous process right there in the middle, you have paraspinal muscles on either side, you have your lamina and your transverse processes. Once you have this view, you make your hash marks with your marker above and below in the midline of your probe. Rotate your probe where it is in space, just 90 degrees, and you have a longitudinal plane. This time, the probe marker is going to face your patient's head. What are we looking at in this image? Yep, yeah, spinous process, potentially the lamina. If we are doing like a paramedian approach, yes. However, this one is technically midline. You're not seeing the lamina because it's just spinous process, spinous process, spinous process. And those are going to be your key visualization landmarks on ultrasound. If we freeze the image, and we have 2 spinal processes that we can see here, what do we think this kind of change in echogenicity that I'm pointing to is? Interspinal. What? What's like the deepest part, that big pop that you hear before you go in? Yeah, ligamentum flavum, flavum, which, you know, whatever you prefer. Another benefit of using ultrasound to guide this procedure is you can see here that you have the depth marking on the side. So that tells you, oh, I probably have to go about 4 centimeters from the skin to pierce through. And so when you're choosing your needle, you can look at the length of whatever needle you choose to get the correct size. You can also use the linear probe. This is a flatter image. The difference between the linear probe and the curvilinear is that it's going to look a little bit wider between the spinous processes, but you can still, you know, identify the spinous processes and then find ligamentum flavum, which is the change in echogenicity in the center in the interspinous area. So you've marked midline in your transverse and your longitudinal views. You have on the left what looks like almost a cross. All you do is connect the dots. And there you go. As a note, because we're not doing every procedure with the patient sitting up, you can also do this with the patient lying down. Finding your midline, finding your depth for the ligamentum flavum for how far that the needle needs to go, and then also making sure that you're in between the spinous processes. As a review, there are benefits to using ultrasound to help guide this procedure. Depth, midline, it can improve your first pass success, and it can shorten your procedure length time. You know, it's like you don't have to turn the lights off because the rest of this procedure is like not even ultrasound images, but that's okay. All right, so what's the evidence for this? Because I know there's a lot of skeptics that, you know, have done millions of lumbar punctures in their career and don't see a purpose of this. Well, first of all, to be honest, I had my like mid-year review with Dr. Hassel, and we talked about how they are considering almost like getting or decreasing the number of lumbar punctures that we need to graduate with because they are becoming less and less common. And as procedures get less and less common, we don't get as comfortable with them. So why not use the tools in our toolkit to improve our success? This landmark study published in 2018 was a systemic review and meta-analysis looking at ultrasound-assisted LPs compared to our traditional landmark approach. And what they found was that when people used ultrasound, they had a success rate of 90% compared to 80-ish% using landmarks. They also showed that patients had fewer traumatic LPs when they used an ultrasound to help guide it. Another study came out a little bit earlier, a systematic review showing that when we used ultrasound, you can actually decrease the amount of needle retractions and redirections. How many of you have done a lumbar puncture where you just pull back, redirect, pull back, redirect? It's like very painful for the patient, and I think a huge potential role for ultrasound in doing lumbar punctures is actually going to be for kids and infants. So this has also been studied where in a tertiary pediatric center, they did a randomized control trial. They had about 128 patients, and their first attempt success rate was higher for those using ultrasound, 58%. Again, not perfect, but so much better than a traditional approach, which led to only a 27% success rate. I would hope that our numbers are a little bit higher than that. Also, last year, there was an article published on using ultrasound for lumbar punctures in children, where they looked at 7 different RCTs with a total of 618 patients. They found that first attempt success rate was 72% compared to a traditional approach, which was 60%. All right, so I would love if you all could just take out your phones and take a photo of this QR code. You can watch this video after. It's really quick. It's 5 minutes watching someone do an ultrasound-assisted lumbar puncture in real time. And as take-home points for you all is that we can use ultrasound to scan in 2 planes, that we connect the dots and we create X marks the spot for where we need to go. We can estimate the depth of the ligamentum flavum, so we can choose the correct needle size, and we can save ourselves time, because we all know that if a lumbar puncture doesn't go as planned, you can be in the room for 30 minutes, pod A is going to blow up, and you're increasing wait times for the rest of the patients in the room. As a disclaimer, this procedure is not going to be for everyone. Because you will have patients where you can see every vertebra on them and you know exactly where to go, and it's really easy. But as the obesity epidemic in America expands and more of our patients have more adipose tissue, it's honestly, it can become harder to do these procedures. And so why not use ultrasound if we have the capability?